Part 3 of Peds Neuro is going to address diagnostic testing. Most of the information that's in here you should have heard about in prior courses, so we'll review it. We do some diagnostic imaging so we can actually visualize some of the abnormalities that occur in the brain. We can do an ultrasound that will indicate fluid, and this is especially helpful when we think that a child has hydrocephalus or they're trying to determine has the fluid accumulated or has it been reabsorbed. It also is excellent at determining an acute intraventricular hemorrhage that occurred in our neonates. And it's non-invasive, it doesn't hurt. CT scans, or MRIs, are also good at looking at tumors, cysts, and abscesses. It can look at bleeding as well as the structures surrounding the bleed. They determine edema, only the presence, but as well as the extent. Once again, ventricular enlargement can be detected, and then we see some of the congenital abnormalities. We can determine that they have no connection between the corpus callosum. We have several children at Altamed that actually have this disorder. They can visualize when the brain is smooth rather than having all of the deep folds that are considered normal. Cerebral angiograms are done when somebody has a bleed, but they will do a CT scan first because if there's an active bleed, we do not want to inject some kind of a contrast that's going to eventually extravasate directly into the brain tissue. So take a look at this. This is a good example of the brain structures. You can see all the deep rugae, and that's what's considered normal. You get a good look at the brainstem. You have a decent look at the ventricles. When you're preparing a child to go for an MRI, remember, this one is very loud. I like to tell them that they're going to be like an airline pilot and they get to wear headphones and it's going to have music and people can talk in it, but they have to stay very still. Other things that you should be very familiar with are going to be the lumbar puncture, and I have a couple more slides that I'm going to show you about it. But what we're looking at is what is the pressure, and so they'll measure that pressure as they go in. They do an intro-exit pressure, and we collect samples. This can be done when they have meningitis, encephalitis, and we also do it in oncology when they're looking to see if there is CNS involvement of whatever type of cancer they have. In the intensive care units, we have brain monitoring. We can actually measure intracranial pressure, measure blood flow, measure oxygenation, and then what they want you to do is maintain the mean arterial pressure according to the MD guidelines so that we're making sure that we're perfusing the brain. So this child is going to have a lot of monitors and tubes that are coming out of the brain. In cases that have head trauma that leads to intubation, we anticipate that there can be increased intracranial pressure for at least the first 3 to 4, and that's supposed to say days. Part of the nursing assessment is measuring the intracranial pressure hourly. And so on the cardiorespiratory monitors that you're used to looking at, but these ones are mounted up on the wall, there actually is going to be one strip that's measuring the intracranial pressure. It also will show you what your map is, and then your vasopressors are going to be adjusted based on that map. Once again, the goal is to maintain the pressure and the perfusion to the brain tissue. The edema resolves, vasopressors are reduced, and then we can extubate the kid and hopefully we're going to have a good outcome. You see that hand in this picture? That's going to be you. You see the other hand that's up holding the shoulder? Hopefully this child has received some type of conscious sedation. When they have a severe meningitis and they just come into the ER, that is not always the case because this kid is already lethargic and we need to do this quickly. But your job in assisting with a lumbar puncture is to make sure this child is held. You'll set up your tray. The doctor or nurse practitioner will open everything up. Everything is contained within the tray, and this is a sterile procedure. What might be different in current trays is instead of using betadine, we use chlorhexidine. On the top right, you can see where that needle is actually going between the vertebrae and it's going directly into the spinal canal so that we can get the fluid. They typically go between the 3rd and 4th lumbar vertebrae. What we're looking for is determining the quality of the CSF. When they're thinking it's a bacterial meningitis, The pressures are going to be high. When you look at the fluid that's coming out as they're collecting it into the tubes, you're going to notice that it isn't that nice, clear, pale yellow color, but it's going to be cloudy. And it's cloudy because it's full of white cells. You know, or you anticipate that this is what the result is going to be because you have a child who is allowing us to do this LP, start the IV, do our assessment, and they're not even moving. That's a very sick child. We'll see an increase in the protein levels and a decrease in the glucose. Let's compare that with the viral. Pressures with viral meningitis can be normal or just a little bit above normal. Now, unlike the bacterial, this fluid is still going to be clear. There's hardly going to be any white cells because it's viral. Proteins are increased, but look at the glucose. It's normal. Think about it. Why is the glucose low in bacterial and normal in viral? The reason is because the bacteria need glucose for replication, and so they are eating up all the glucose that's in that spinal fluid. They can make the infection worse. That's an important point for you to remember. Other diagnostics related to neuro disorders will be your EEG. They can tell the actual type, exactly where it is, and how long it is. And we have the standard EEG where they put all of the leads all over the head and they conduct it over about a 15-minute period, or they can do continuous telemetry EEG monitoring. And they have an EEG tech that is monitoring all of the telescreens, looking at the child, looking at the EEG results so that they can document when a child has a seizure. When we're doing this, we also have a camera on the child in the room. They can do a neuroimaging study in the form of a CT or MRI, and then also with an EEG, we can do auditory and visual evoked potentials. And so they'll either do an obnoxious noise or they do repetitive light because there are some people whose seizures are triggered by this. One of the video games that was developed in Japan started causing a lot of children to have seizures while they were doing it. And they found out that there was a red light that would blink on and off, on and off, on and off. And it was enough to trigger seizures in kids who we didn't even know had a seizure disorder. So they've since removed that type of lighting effect in these games. Some metabolic indicators that we're going to look at, i.e. lab tests, will be your blood count. So once again, bacterial type problems, we're going to see a high white count, whereas in viral, you would anticipate low. We'll look at their electrolyte level because along with the infection, they may not be eating or drinking or voiding, and so our electrolytes will be abnormal. We do a glucose level because when someone is hypoglycemic, they can have a seizure. That's one of the first things paramedics do when someone has a new onset seizure is they're just going to do a D-stick on them and see, oh, they're having that because they have no blood sugar. And then we do tox screens because remember, children are curious, everything goes in the mouth. So then our infection indicators, the CSF, cultures, and CBC. We'll do an LP, send it off. They will do a gram stain looking for the bacteria, send off cultures, immediately initiate your antibiotics. For children who have a known seizure disorder who are on anticonvulsants, we're going to do a variety of anticonvulsant levels to see if uncontrolled seizures are due to their levels are too low, or in children who are exhibiting side effects that they might be too high and need adjustment. This ends part 3 of neuro diagnostic testing.